Okay. Mhm. So we have come once to this place, All India Institute over there to do an echo workshop over there.
Yeah, yeah.
Yeah,
Yeah, last year it was there.
yeah, it was there. So
Yeah.
we
So,
came.
is there a Manipal hospital in Bhubaneswar, sir?
Manipal Hospital is there. Yes.
Yeah, one DM Neotal is my senior, sir.
Janki is there.
Janki is my senior.
Okay. That's
in
nice.
D-
That's
D.
nice.
Janki did a fellowship with us at Rainbow.
Yeah. Vijayawada.
Yeah. Right.
He did from Secunderabad Rainbow, then he moved.
Yeah.
Yeah, who else has to join? The other panelist is.
Good evening, sir. I have joined.
Yeah, hi.
I'm
How are
Dr.
you?
Saurabh from Noida. All good, sir.
Saurabh.
How are you?
Fine. So you're from
I'm from Noida, sir.
Noida, yeah. This which hospital?
Cloud9 Hospital in Noida.
Cloud9. I think Sanjay was there, no?
He's in Gurgaon. I mean, he was in Gurgaon, then he left for motherhood. He's currently in Motherhood Hospital, Gurgaon.
Okay. So he was there in your hospital, right?
No, sir. It's a different branch of Cloud9 in Gurgaon.
So where have you finished your education, and since how long are you in practice?
Sir, I did my DNB neonatology from Kanchi Kamakoti, Chennai, and finished in 2019.
Oh, very
So
good.
past 6 years I am in Noida only.
Same hospital?
Same hospital, sir.
Cloud9. Very nice.
Cloud9, sir.
Good. So how many have joined? 41 participants, 40?
Just wanted to introduce for rest of my panelists. So I'm Dr. Surinder. I'm consultant neonatologist at Rainbow Children's Hospital in Secunderabad. So I'm attached to Rainbow for last 18 years now. So I head the unit here. It's a 33-bed NICU. So currently I'm practicing in this part of the city.
And he has, organized a wonderful state conferences, 2 of them.
I've been past secretary and vice president of Telangana State NNF.
So now you are also this
No, sir. Last December 2024, I finished vice president, sir. After that, no more portfolio.
You don't want to go to the take up president? No, not it.
There is, I think, few of my seniors who are in the pipeline, sir. Probably when my number comes, then.
Very nice. Dr. Mahapatra, you are muted.
Sorry, thank you, sir. So I think 40, more than 40, 48, 49. So we can start. It's 8:35.
Yeah.
So what I'll do.
No, are the participants also now there? They can see us?
Yeah, I think yes.
Okay.
Yeah, they should be. So very good evening. Very good evening to all the respected faculties and participants. So this is the ongoing NOEL program, basically aimed at the fellowship centers, the fellows, and of course, anyone else interested can join. So today we have got a very exciting panel discussion on hemodynamically significant PTA, led by very senior neonatologist of the country, I would say, Dr. K. Ravisankar. who has got more than 25 years of experience in neonatology, having done his MD as well as DM neonatology from PGI Chandigarh. Currently, he is medical director of Somya Children's Hospital in Hyderabad, and formerly he was professor of neonatology in Osmania Medical College as well as Nilofer Hospital. And to aid him in the panel, we have Dr. Saurabh Kotaria, who is DNB neonatology from Cloud9 Hospital in Noida, and Dr. Niranjan, who is a DM neonatology again from Yashoda Hospital, Sikandrabad, and Dr. Surendra Rao, who is again a neonatologist from Rainbow Hospital in Sikandrabad, and Dr. Jafar Khan, neonatologist from Indore. So over to you, sir, Dr. Ravi Shankar, for an exciting session ahead.
Yeah, I didn't see Dr. Jafar. Has he joined?
I don't think he has joined. No, he hasn't. So, sir, you can start. I'll give him a call.
No, we'll wait for him to join because it will flow, no? Then otherwise.
Yeah, that's true. Okay, let me
Can you
try
give me a call?
calling.
Somebody can give me a call once. Yeah, in this WhatsApp group, I think nobody actually interacted much. So I was just,
Yeah.
I was wondering they must be super busy persons, everybody. So yeah, if he's not going to join, I think we will continue. We'll ask one of the other three to answer. So let us start then. I think we have 60 and we are already 8:40. So I will share my screen.
So he has joined, but he's not. Probably he has joined. He has joined. I talked to him. He has joined probably in the normal link, not in the faculty link. So he's not able to get his audio. I told him to join in the faculty link. So just let's wait for a minute or two.
So you can see the screen?
Yes, sir, we can see.
Yes.
Sir, you have to do screen share.
I have done, na?
No, sir, we are not able to see. Yes, sir. Yes. Yeah, right. Now it's visible.
Oh, it's visible?
Yes, sir. Yes, sir. It's visible.
Shall we start or wait for him?
Just let me call him again.
I would, request all the faculty to put on their videos because they would want to see us, no?
Ajit sir, Ravi Shankar sir.
Hello.
Greetings.
Hi,
How are you,
Gideon.
sir?
How are you?
Fine, sir. Fine, sir.
Fine, good.
I think we're all looking forward to a wonderful discussion, sir.
Yeah. So it is not
Hi,
going to
Girdhar.
be
Is there
Wi-Fi.
would be.
Hello, sir. Ajit sir. How are you, sir?
Yeah, I'm good. Girdhar, just help. Dr. Jafar is not able to get into his audio. He's saying that he has joined, but
Sir, I think ask him to actually rejoin, sir. Come out and rejoin
no,
again.
I
Okay,
told
mostly it
him.
happens. Still,
I
it is
told him.
not coming, sir. Oh, usually it rectifies. Okay, I'll just try to contact Debarun. I'll see whether he could join to some other route, sir.
So in the meantime, shall we start?
Yeah, we should start. He told that same thing.
Okay. Fine then. So we will start and
I think let's start.
Hmm.
Yeah, let's start. Yes, he's there.
Yeah, good evening, everybody.
He's there.
So we are going to have some kind of panel discussion on PDA, which we talk very often in our NICU, whether it is there or not, when to treat, how to treat, and what it is going to do. So actually, PDA has been an enigmatic condition. So it is, we know about PDA being physiological, and we know that in premature babies it can cause problems, but we have been able to diagnose it. We have been able to clinically diagnose it. We are able to um, do an echocardiography. We are able to find out whether the baby has a PDA or not, and whether it is going to cause some kind of problems like hemodynamically significant or not. But what is the problem is that we don't know whether to treat or not. So there is a lot of debate and kind of papers are there about this PDA. PDA is a normal structure, a very important structure to support the fetal circulation. But after birth, it should physiologically close down. But this issue of PDA has been the point of discussion in all the people, all the neonatologists and all, as to whether it is going to improve the outcome or not. So to discuss for the benefit of all the fellows and others, we thought we will go through the entire spectrum of what is this PDA and all those things, and not only about one aspect of it. So we will try to finish it off in about 45 minutes or 1 hour. And with us we have four um, panelists who are all experienced in their own fields. So I will ask them some questions, and they will tell us their point of view. So the first question is to Dr. Surinder. So PDA is a normal thing, and it just closes down in about 24 hours in all the term babies. Why PDA closure is delayed in premature babies?
Good evening, all. We all know that normally in full-term babies, the PDA closes very rapidly once the first breath is established. So, but whereas in premature babies, lesser the prematurity, less the gestation age and birth weight, the incidence of patent death start cases is high. To speak, it is exactly inversely proportional to the
Just
gestation age.
Surinder, there is an echo. If you are on mute, devices, you need to close one of them.
Nothing, sir. I have only one.
Are you on the mobile phone and laptop also, both of them?
Nothing else, sir.
Or some other person is there with you?
Hello.
There's a lot of.
Am I audible?
You are audible, but there is echo.
You can switch off the one of the like phone or laptop.
So this echo is coming for everyone, I suppose. I don't know.
It's for everyone, sir. Not only for me.
So why is it so?
It's actually somebody would have logged in from 2 devices nearby.
So
Nothing else, sir. I'm doing only from my device.
now it's okay. I think now it's fine.
Okay. Is it clear, sir? Am I audible?
Yes, yes.
So the incidence of PDA is inversely proportional to the gestational age at birth weight. So normally what happens?
Again, it started.
So normally after establishment of the first breath with good oxygenation, the ductal arteriosus closes after initial vasoconstriction, followed by there will be hypoxia-induced vessel in the vessel wall. There will be hypoxia, followed by there will be proliferation of the cells, and there will mediated by vascular endothelial growth factors, and subsequently it leads to formation of the mold. Now, to happen all this, there are certain factors which will be detrimental, especially in premature babies. Prematurity per se can cause because of the anatomy of the vessel wall, or the vasodilators per se, or the oxygenation sensitivity. All these factors will be detrimental in leading to patency of the ductus arteriosus. So first, if we look at the oxygenation, now there will be decreased oxygen sensitivity and immature oxygen sensing, which can lead to patency of ductus arteriosus in premature babies. Similarly, there will be increased sensitivity to the vasodilators like prostaglandin E2, and because these premature babies, normally prostaglandin E2 is cleared through the lungs, and in premature babies, because of the decreased clearance, which can again lead to vasodilatory effect of the ductus arteriosus. And as we were talking about the structural immaturity, because of the thin vessel wall and decreased vascular tone, it might not constrict properly because of decreased myosin activity. And all these factors will lead to patency of the ductus arteriosus. Similarly, there is another entity where the chances of reopening are also possible in premature babies. Suppose in case the mothers who did not receive antenatal steroids, or in case because of iatrogenic reasons like fluid overload, or other these vasodilatory effects itself, as we see in the delayed primary closure of the ductus arteriosus, and poor myocardial contractility, which will not be able to handle the volume overload from the duct. And sometimes infections like sepsis or chorioamnitis or any inflammation per se can lead to delay in closure of the ductus arteriosus in these premature babies.
Yeah, thank you. So what it means is that it is a known fact that the more the baby is premature, the less likely the duct will close down in time. It will get delayed. So let us see, but then eventually most of the ducts will close down. So we would want to know, how the ducts actually close down. So we want to know from Dr. Saurabh, what are the spontaneous closure rates? So do they actually close down? How much time it takes, at what gestational age? So can we ask Dr. Saurabh to tell us what are the spontaneous closure rates? Yeah. Dr. Saurabh, are you there? Your video and this audio is off, I suppose. Dr. Saurabh, are you there?
Hello.
Yes.
Now, good evening, everyone. You can hear us, sir?
Yes, we can hear.
Yes. So basically, PDA closure regarding PDA closure ratio in preterms, PDA is seen usually in 1 in 2,000 births, and PDA incidence is inversely proportional to the gestational age as well as the birth weight. So the more the preterm baby, the lesser are the chances the PDA will close by itself early in the stage, as well as the birth weight. So if we see in extremely preterm babies, those who are born before 28 weeks of gestation, and those babies who are less than 1,000 grams of birth weight, by the day 4 of life, early closure rates is only seen in 1/3 of the babies. That means around 33 to 34% of babies, and by day 7 40% of the PDA closes. So that means more than 50% of the babies by 1 week of life will have patent ductus arteriosus in extremely preterm babies. So the key finding here is the most extremely preterm PDAs will remain open in first week of life, and due to, as discussed earlier, due to prematurity of lungs, like in RDS, where there is increased prostaglandins, which will lead to increased vasodilation, the PDA can remain open in preterm babies. The median time of closure by gestational age, as we see in this slide, is that by in those babies who are born at around 26 to 27 weeks of gestational age, 13 days is the median closure. And as the gestational age increases by 28 to 29 weeks or more than 30 weeks, it decreases to 8 days, then to 16 days. That means earlier the GA, longer time it takes to close. And as we see by birth weight, those babies who are born less than 100 grams of 1000 grams of birth weight, and between 1000 to 1250 and more than 250, the days is 22 days, 9 days, and 8 days. So again, which shows that lower the birth weight, it increases the closure time. So what are the predictive factors and what is the prognosis? It's that if we see each 1 week increase in gestational age after 23 weeks of gestation, the odds of closure increases by 1.5 times. And basically by 36 to 44 weeks post-menstrual age, majority of the PDA will close spontaneously. So it's inversely proportional. And in term babies, basically it's a functional defect. And in preterms, it's all because of prematurity. So that's why preterm babies will lead to closure of ductus spontaneously in majority of the cases.
Yeah. So what we have to understand is that, eventually most of them will close down. It may take a long time, but it may take a month or two or so. By term, most of them will close down. They are not like PDA of term, like those who have a PDA as a congenital heart disease, that won't close down. But PDA of prematurity will definitely close down. Most of them will close down. It's not going to persist for the entire life. It may take some time, but it will eventually close down. So I'd like to ask Dr. Niranjan, what are the cardiovascular changes which occur in PDA? So what is its effect? What kind of an hemodynamic disturbances can occur because of the PDA, especially when we talk about a premature baby with PDA?
We all know PDA is a connection between pulmonary artery and aorta. So it's normal in the fetal circulation. Once the baby is born, postnatally it will close. the persistent opening of the PDA, it causes serious effects in the premature babies. And hemodynamics also. Like the severity is depend on the size of the PDA and then the direction of the flow and gradient across the PDA. This is the very important. So if it is like once a baby is born, like pulmonary vascular resistance will falls and create a pressure gradient, causes a left to right shunt due to more blood passing from the aorta to pulmonary artery. It causes a more pulmonary circulations. It causes a pulmonary edema and pulmonary congestions. So continued flowing of the blood, it leads to finally pulmonary hypertension and complications like pulmonary hemorrhage will cause in the premature babies. And then once it's like a left to right shunt is like a vicious cycle. So once initially pulmonary circulation will increase, then later on venous return to the left atrium, left ventricle, it causes a overloading of the left atrium, left ventricle. Premature babies are like myocardiums already immature, where they are very unable to handle a high afterload and preloading things. Due to that, they will ultimately they'll develop a LV dysfunction and myocardial ischemia. Due to cardiostyle, like ductal steal phenomena, in diastolic, in relaxation, diastolic flow has to go to the aorta. Instead, diastolic flow through aorta, it has to go to the systemic organs. So instead of going to systemic organs, all the blood will bypass to the pulmonary circulation. It causes a ischemia to the systemic organs like kidney and intestine. So leads to complications like NEC, acute kidney injury, and all it will causes.
Yeah. So what it is going to cause a lot of problems. And if you see this slide, and if we know, it can cause sometimes devastating problems also. So it is a multi-organ involvement. The lungs and the various organs in the body. It has been attributed to IVH and BPD and this hypotension, everything. So a lot of hemodynamic disturbances will occur if PDA is there is a significant left to right shunt. So that is the quantum of a problem which we can have. So let us go to the next question. So if these are the problems, Dr. Jafar, what are the clinical signs and symptoms of PDA?
Sir, are you able to hear me?
Yes, we can hear you, but we can't see you. Can you just open your video?
Is there, no, sir, NNF faculty? This
Yeah,
one.
but is there? But
Okay.
I think it will be nice if you just on your video also. It will be good. Yeah.
Yeah, it is there, I think. It is there.
No,
Okay.
no.
So,
Okay.
what are the clinical signs we have in PDA? They are very subtle and they are non-specific, unreliable, and they are subjective. They may mimic sepsis or RDS. Sometimes like the baby looks pale, so we can suspect sepsis, or if baby is having some pulmonary over circulation, they can like feel like a respiratory distress syndrome. So usually whatever symptom they occur after 3 days of life, and most of the time if we have the symptom, they lag by at least 1 or 2 days by echo finding. So first the echo finding comes as a PDA significant, and the what are the symptoms occur after 1 or 2 days of the PDA. So like just Dr. Niranjan has said that there are symptoms related to two circulation. One is pulmonary over circulation, and the second is due to systemic hypoperfusion. So due to pulmonary hypercirculation, there is a two system involved like cardiac signs and vascular signs. In cardiac sign, there could be a murmur, but most of the time in preterm, the initial stage, there is a no murmur. Murmur can appear, but it is late by at least 1 or 2 days after the PDA diagnosed by the echo. So echo is the very initial diagnosis of the echo. Most of the time, the murmur may be machinery, maybe only systolic or holocystic. And other signs, what we find from the echo is like tachycardia, heart rate may be more than 160 to 180, hyperdynamic precardium, visible, palpable heartbeat we can see, and usually it appear after 3 days of the worsening PDA. Other signs we can see like the palpation, pulse can be bounding, palpable palmar pulses, the white pulse pressure like more than 30 millimeter mercury, hypotension could be there, especially low diastolic pressure, and it could be refractory hypotension if there is a significant PDA is there, and sometimes it may need vasopressor support. But if we go to the systemic hypoperfusion, there could be signs of respiratory symptom like worsening respiratory symptom. Like if baby is on CPAP, the baby might require high FiO2, baby might require uh, high pressure and increased ventilatory needs. And sometimes if we are going to wean the baby from CPAP or ventilation, we are unable to wean. And may the baby have recurrent bradycardia or recurrent apneas, tachypneas, increased work breathing. And if we go to the X-ray, there will be pulmonary hyperemia. Yeah, there may be cardiomegaly. And other signs which is related to systemic hypoperfusion like feed intolerance, oliguria, renal dysfunction, poor weight gain, metabolic acidosis, lethargy. And if that PDA is not detected early and the volume overload going on, there could be a pulmonary bleed and the baby may succumb because of pulmonary hemorrhage and PPHN.
Yeah. So many aspects, so many things can happen, which are predominantly because of pulmonary over circulation and systemic hypoperfusion. And these problems can be this can cause more stress on the smallest of the babies. So the smaller and the lower gestational age, we are going to have the hemodynamic effects are going to be maximum. And as has been told already, the clinical signs may not be very much apparent initially. It may take some time as the pulmonary vascular pressure drops down. So we have to, so this classical normal PDA, what we see in pediatric age group, that's not the kind of PDA which we see in the preterm baby. So we have to think about all these things. We have to assess what are the various problems which are happening because of PDA in a premature baby. So I'll come back once again to Dr. Surinder. Are there any clinical scoring available for PDA? There are so many things are happening. There are lung findings, there are epistemic findings. So in our day-to-day practice, when we go to the patient, are there any kind of clinical criteria available to say that this baby might be having a PDA?
Basically, there are two types of scoring systems which I could find. So one is the simple scoring system that will just predict based on a few factors like maternal history of chorionitis or weight of the baby and the need for mechanical ventilation, blood gas, cord blood gas. Like so many, around 14 variables are there with a score of around 29. And it was found that if the score is at 6 hours of life, if it is more than 8.5, sensitivity and specificity to be around 90 to 95% respectively. And whereas if the score is more than 6 at 72 hours of life, sensitivity is almost 100% with specificity of 94%. So, but this one is in limited resources places where timely echo cannot be accessed. Whereas another clinical tool like cardiovascular disease score is there, which is based on clinical parameters like your, if you look at the cardiac activity, heart rate, or bounding pulses, wide pulse pressure, and respiratory the tachypnea, or suppose if the baby is on mechanical ventilator, clinical condition got worsened where we have to go upon the ventilatory settings, and systemic hypoperfusion findings like abdominal distension or decreased urine output, renal hypoperfusion. So these criteria, clinical criteria, which will foresee us to go for a confirmatory diagnosis and get a 2D echo done. So these are the two basic scoring systems, but one each of us they have their own limitation. So still this cardiovascular scoring system, cardiovascular disease scoring system finds to be foolproof, and it is more authenticated, and we can also have a confirmation by getting a 2D echo done.
Yeah, that's fine. So what we have to tell everybody and what we have to follow is that PDA can be predicted by clinical findings also. So we can which can help us say that when to do an echo. But these days echocardiography has come in almost every NSU, and we don't actually look for all these signs. But these are some of the, especially this simple score has got the evidence. There are studies which have been done, and which have shown that it can predict. But these days they don't. I mean, people don't actually follow them. The more widely followed is the cardiovascular disease stress score, which is based on these five things: that what is tachycardia, pounding pulses, murmur, precordial activity, and this cardiomegaly on the X-ray. So what we have to remember is that there are some clinical signs available, clinical tools are available, which can help us suspect that this baby might be having a PDA, and when echocardiography may be required. But echocardiography is a gold standard. Without that, I think we should not go ahead and treat. There were days when we used to treat, we used to think that the child has PDA, and we used to give indomethacin. It was almost 25, 28 years back. I was a PG, and we gave indomethacin to babies based on this clinical criteria only, that cardiovascular stress score. But that is gone now. So now it has got replaced by echocardiography. This when we have a little doubt, we do the echocardiography and find out. But we need to know that clinical scoring is available. So last now, Dr. Saurabh, what is the optimal timing to perform the echocardiography? So, because we know that some clinical signs may not be apparent initially, so what is the apparent? What is the optimal time to evaluate for PDA by performing the echocardiography in preterm infants?
Good evening again. Basically, there are no universal guidelines which can tell us specifically that when we have to do the echocardiography for any of the preterm infants. So there are multiple strategies which are followed all over the world. So which can be an early screening, which is before the baby becomes symptomatic, that is around 1 to 3 days of life. Then there can be a prophylactic where we do it on between 3 to 7 days of window when we expect the most of the hemodynamically significant PDA to occur. Then there is symptomatic trigger, that when the baby is asymptomatic, there is nothing to be done. Whenever there is doubt or those symptoms which we got to know earlier in the earlier slides, when those symptoms occur or when the expected PDA is there, then only we have to do. These are the multiple strategies that we can do. So some units will perform early screening. So usually what happens is whenever there are highest risk babies, that means those babies who have highest risk of getting hemodynamically significant PDA, that means those extreme preterm babies less than 26 to 28 weeks of gestation, or those babies having lower birth weight, like less than 1000 grams or less than 750 grams, an early screening echocardiogram within first 3 days, that means within 24 to 72 hours of life, can be done. With purpose is not to diagnose or to start the treatment in those babies. The purpose is just for risk stratification and prognostication. We should not start immediate treatment based on those findings when the baby is asymptomatic. And after identifying a high risk PDA, we should prompt intensified clinical monitoring and have a lower threshold for a follow up echogram if the baby's clinical status changes. And some guidelines also suggest that early targeted screening, sometimes for infants who are born less than 28 weeks of gestation, at first 2 days, that means 36 plus 6 hours and 72 plus 6 hours, and on day 7 of life. Those babies who come under lower risk of hemodynamically significant PDA, that means those babies who are born with more than 28 weeks of gestational, we can do a symptomatic triggered diagnostic echocardiogram, or between day 3 to day 7 when there is a sudden fall in pulmonary vascular resistance, and that leads to increased blood flow to the PDA left to right shunt, and which cause symptomatic PDA. So this often usually occurs between postnatal day 3 to day 7, and during this time, in most of the babies, clinical symptoms may become apparent. And what are the clinical triggers as discussed earlier? It might be increased work of breathing, tachypnea, increased requirement of ventilatory settings, bounding pulses, widened pulse pressure, hyperactive pregodium, tachycardia, hypotension needing inotropes. So these are the symptoms where we can do symptomatic triggered diagnostic echocardiogram. The next step is when to do a follow-up echocardiography. So there are two things, whether depending upon what we are assessing. So first is when we are assessing response to a pharmacological therapy. So always when we have started pharmacological therapy in view of paracetamol or ibuprofen, a follow-up echogram is mandatory to see whether the treatment is working or not. And it's typically performed within 24 hours after the administration of the last dose of those medications. Plus, we have to keep on monitoring in conservative management. For example, in high-risk infants identified on initial echo, more frequent surveillance may be prudent to detect a worsening shunt. And for those infants with a confirmed hemodynamically significant PDA, which are being managed conservatively, a repeat echo around 3 to 7 days, or there is clinical deterioration, then we can do it sooner, which can be often considered to reassess the significance of PDA.
Yeah, that's right. So you have just nicely pointed out saying that doing an echo does not mean that you have to treat. So echo is like our clinical examination, and you have pointed out that those who are below 28 weeks, we may do an echo and see, and follow-up echoes have to be done. If the echo is showing a PDA, we have to closely monitor for the clinical signs, and we have to see when to treat them. So doing an echo and treatment are not the same. It doesn't mean that you have to go ahead and treat. And most of us actually do an echocardiography when the baby is having some clinical signs. So that's the time. So doing frequent echoes, if it is possible, please do it to understand the physiology, but not essentially to treat them. Next, what are the echocardiographic views for PDA assessment? And just to start off the echocardiography, I think I'll ask Dr. Jafar about this.
Yes, sir. There are different views. We can just assess the PDA views. So the standard view, what we most of the time use is the high left parastral ductal view. That is we call as a ductal view, where we can visualize the duct and we can measure, and we can just see the ductal structure as well. We can see the flow of direction. We can see the size and morphology of the duct, and this is we can do repeated echo by this view. And there are other view as well, like supraesternal notch view, where we can see the aortic arch, we can see the duct flow, we can see the duct pattern as well, and we can see the surrounding structure as well. The other view which we just give the opportunity to see the left atrium and ventricular dilatation as well, like parasternal long axis view, where we can see the left atrial and left ventricular dilatation. We can see the LA-AO ratio, and we can see the if the duct is significant or not, and we can see the dilatation of cardiac chambers. And other views are like subcostal view, where we can see the abdominal aorta, and we can see the ductal still diastolic still phenomena by looking at the SMA superior mesenteric artery as well. And here we can see the septum and foramen ovulation. Other we can see the like chamber view, where we can see the all the four chamber. We can see the continuity of the all the two chambers. We can see the tricuspid regurgitation, and we can see the secondary effect of the duct on the pulmonary patient as well through apical four chamber views. But most of the time we use the ductal view for the assessment of the duct size and follow up of the duct size after treatment or during treatment therapy.
Yeah. So what it means is that, see, he has mentioned about all the areas. So it is just not only the ductal view. So you cannot just put a probe in one area and say the duct is present, and then you start your treatment. So a ductal evaluation means you have to do a complete echo. All the areas, the parasternal, suprasternal, parasternal, long axis, and subcostal, apical, fourth chambered. All the views have to be. So complete evaluation has to be done. You should not do a partial evaluation. So let us see what are the findings, echocardiographic findings in PDA. Can I ask Dr. Niranjan to tell us about what are the echocardiographic findings?
Yeah. So echocardiography and Doppler studies is a very gold standard for diagnosing the PDA. Not only diagnosis, for management is mainly depends on the echocardiography findings. Already, sir has said like there are few views like high parasternal, short axis view, and four chamber views. These are the few views are most commonly used for assessment of PDA. For echocardiogram assessment, we broadly divide into three features, like one for the ductal characteristics, and then PDA causing the over circulation in the lungs and left heart loading, and third one is the due to ductal steal phenomena that causes systemic hyperperfusion. We'll discuss one by one. In ductal characteristics, first we should assess the size of the duct at the narrowest part actually. So classically,
Sorry, sir. Sir, can I join? I'm back.
You want to speak?
Yeah, sir. This HSPDA, yes.
No. I think we will wait for you.
Oh, I'm sorry, I got disconnected, sir. I rejoined.
Yeah, fine.
So echocardiography findings and Doppler study will discuss on 3 points. One will be ductal characteristics, and another is the pulmonary over circulation and left heart loading, and third one is systemic hyperperfusion due to ductal steal phenomena. In ductus, like mainly we should assess the size. In the short axis view, we should check the size at the very narrowest part of the ductus. So normally, depending upon the size, we'll divide it into mild, moderate. If it is 1.5 millimeter, we'll consider as a mild, and 1.5 to 3 millimeter, and more than 3 millimeter, we'll consider severe PDA. Large PDA will consider. And along with that, we should measure the PDA size, PDA with left pulmonary artery ratio. The ratio is more than 1. We'll consider as a large PDA. And if the ratio between 0.5 to 1, we'll consider as a moderate, and ratio less than 0.5, we'll consider small PDA. And along with that characteristic, like whether it is a restrictive pattern or unrestricted pattern, and then the flow of the pattern of the PDA also should check. So if it is the flow of the pattern is like right to left shunt, it's a way contraindicated for closing the PDA, because in this condition, if you do a closing of PDA closure, they'll land up in pulmonary crisis and severe LV dysfunctions. And for pulmonary over circulation due to persistent PDA, pulmonary circulation, increased pulmonary circulation causing the increased venous return, causing left atrial and left ventricular enlargement. In the short axis, long axis, we will take a ratio of the left atrium aortic. If the ratio is more than 1.5, we'll consider as a significant, and we'll assess the left ventricular output also. If it is normal output, it will be 100 to 300 ml. If it is more than 320, you will consider as a left ventricular output is a significant in PDS. And dimensioning, we can take it in the four chamber view. We'll assess the left ventricular end diastolic value, and if the dimension is more than 15 mm, we'll consider this a significant severe PDA. And mitral valve dysfunction, diastolic dysfunction, will four chamber. We'll put a Doppler at the mitral valve. We'll assess the EA ratio. If a EA ratio is like more than 1, we'll consider it's a diastolic severe diastolic dysfunctions. And if due to ductal steal phenomena, so most of the blood will bypass to the pulmonary circulation. It causes systemic hyperperfusion to the all the organs. So systemic hyperperfusion is assessed by the few of the Doppler in the aorta, descending aorta. It will show the reverse diastolic flow. It's mild. In mild cases, there is the end diastolic flow will be reduces. In moderate cases, absent diastolic flow will be there. In case severe cases, complete reverse diastolic flow it will be there. Same in middle circulatory artery also, there is a reverse diastolic flow. If it is there, means you can suspect, we can anticipate IVH due to PDA complications.
Yeah, so we can, evaluate the duct, we can evaluate what is happening to the lungs and what pulmonary circulation, and also we can evaluate what is happening to the flow to the various parts of the body by echo. So that actually helps us understand everything in a proper way. So this is about the duct. I think the ductal size can be calculated. This is the parasternal short axis. Then we can also see the shunt direction, whether it is left to right shunt or it is bidirectional shunt or it is pure right to left shunt. Because we should ever treat the bidirectional shunts and the right to left shunts. Then we should also see what is the type of flow, as has been told, whether it is a restrictive flow or a non-restrictive flow or a bidirection. By the help of the Dopplers, we can actually tell what is the direction of the flow across the PPDA. We can also tell by the apical four-chambered view what is happening to the size of the left ventricle and the left atrium. We can also measure the left atrial diameter in comparison to the aortic root, which is called as an LAAO ratio. We can also see whether there's an increase in the size of the left ventricular size, that is left ventricular and diastolic diameter. We can also see what is happening to the transmitral flow, as has been told already, whether the E wave is more than the A wave or not, which helps us tell whether there is a left atrial overload. Then we can also see the IVRT, which is isovolumetric relaxation time in the same view. And if there is a hemodynamically significant one, it becomes shorter. We can see what is happening to the velocity of the blood flow in the left pulmonary artery, especially in the diastole, and that also helps us. And we can also see the Dopplers in the pulmonary vein by this Krabs view. And then if the D wave is more prominent when compared to S wave, then it means that it is a hemodynamically significant one. We should also calculate the left ventricular output and see whether, because the PDA will always cause left ventricular overload and left ventricular output will increase. That actually helps us. And we have to, as has been told, we have to see the Doppler flow in the descending aorta, whether it is forward flow or whether it is absent or reverse flow. Same is the case with ciliary artery Dopplers in the abdominal ultrasound and with the middle cerebral artery diastolic flow. So these all things will actually help us whether what is happening to the what is the hemodynamic significance. So I'll now once again I just want Dr. Surinder to tell what is an hemodynamically significant PDA. Just concentrate on the important ones because we have already touched about that. So we have what to check, but we would want you to tell us what is an hemodynamically significant PDA when you want to actually consider treating them.
Yeah. So basically, hemodynamically significant PDA, we should be evaluating based on three parameters. One is the clinical criteria, and one is the echocardiographic findings, which is the gold standard, and next is the biochemical markers. So one is the first one, as the doctor has already raised and clearly evaluated, told the points regarding the echocardiographic findings. I'll go upon the clinical findings, like cardiovascular findings. There can be tachycardia, bounding pulses, hyperdynamic precordium, and wide pulse pressure. There can be hypotension needing vest pressure support. Similarly, respiratory, when we look at, there might be, if the baby is on oxygen or needing for going for invasive ventilation, or if the baby is already ventilated, going upon increase in the oxygen requirement or pressures. And there might be also entity like uh, difficulty in weaning from mechanical ventilator as well. Similarly, if we look at the systemic side effects, there can be oliguria because of the decreased renal perfusion, less than 1 ml per kg per hour, and also decreased perfusion to the gut. There can be abdominal distension or feed intolerance. NEC can happen in these sort of babies because of ductal steal mechanism and metabolic acidosis. I will not go to the echocardiographic findings because already doctor has raised those points clearly. And another one, biochemical markers are brain natriuretic peptide. This will help us to find out the amount of shunting and as well as the level of stress caused in the myocardium of the heart. So these basically all these parameters, after the evaluating clinical parameters, then we will go for a 2D echo and then confirm and then only decide about the treatment.
So, what you're trying to say is that the clinical criteria are very important. HSPDA doesn't mean only the echocardiographic findings. If you find if the child is completely asymptomatic, you not want to treat it, even if the child has a hemodynamically significant PDA on echo, because there it is important to have some clinical features. We have to see what is it causing clinically. So without the clinical criteria, HSPDA cannot be diagnosed. That's an essential point, I think, which is very important. It is not only an echocardiographic diagnosis, there is a clinical component to HSPDA. And as has been told, the echocardiographic evaluation is ductal characteristics, pulmonary circulation, and systemic hypoperfusion. So all these things have to be evaluated. So, but are there any kind of clinical plus echo scoring to say that this is HSPDA? So, I'll ask Dr. Saurabh to tell us about this.
Yes, sir. There are multiple staging systems which can help us in diagnosing and making our treatment decisions, out of which we can discuss four of them. One is McNamara staging system, which is the only one which combines clinical signs with detailed echocardiographic staging system. So it includes clinical signs assessment, which are oxygenation index, the episodes of multiple oxygen desaturations, bradycardia apnea, any need for respiratory support, feed intolerance, and it also includes radiological evidence of increased pulmonary flow. And it also has echocardiographic symptoms like ductal size evaluation and left heart overload and systemic seal assessment. So the clinical systems, they have staging from C1 to C4, and echo have E1 to E4. So combining those stages can help us in assessing the severity. Then another one is Helfast score, which tells us PDS severity score, in which it has only gestation.
Can we ask somebody who is speaking to please mute? Can we ask you to just mute, please? Yeah, Dr. Sirs.
Yeah. So the
madam, आप कौन हैं? Can you mute?
Sir, we can mute all from the admin side.
Dr. Ajit,
yes, sir, I'm there.
can you just mute that particular person? She's speaking.
Which I think from the office they have to do it.
She's on phone. She's on phone and speaking. या मैडम जी आप कौन हैं? Can you please excuse us? Can you mute yourself?
I think it's done, sir.
Yeah. Fine.
Yeah. So the next scoring is L-COFA score, which shows us PDA severity scoring, which combines only gestational age along with the other echocardiographic features like PDA diameter, maximum flow velocity, left ventricular output, and LVA wave, which is seen on tissue Doppler. And the rest two scores are pure echocardiographic scoring system of IOA, PDA score, as well as SZMC score. So Iowa PDA score has 6 parameters which are graded from 0 to 2, apart from only aortic diastolic flow pattern, which shows us whether it's a forward flow or a reversal flow. Rest all like mitral E wave velocity, IVRT, pulmonary valve D wave velocity, L aortic ratio, and LVO RVO ratio, they are all graded from 0 to 2, and that's then assessed about the severity of PDA. And the last score is SZMC score, which has 4 key parameters, which is PDA diameter, LAO ratio, retrograde diastolic flow, again in the abdominal aorta, as well as ductal flow, shunt flow pattern, which tells us whether the ductus is significant or borderline or insignificant. So these are the 4 staging systems which can help us in diagnosing the severity of ductus.
So the scoring is available because so many parameters are there. So many parameters in the echocardiography and the clinical there. There are some scoring available, but people are not using it. These are still as academic only. But I think it's time that people start to look at it to be more kind of objective. And if you see all the studies, nobody actually does this kind of scoring. So scoring is an essential part of a comprehensive evaluation to be more precise and more kind of objective. So that alone can actually help us tell in a proper way whether we are dealing with a hemodynamically significant PDA or not, because otherwise we will not be able to tell in a proper way. So let us now come to the treatment part. Dr. Niranjan, what is the optimal time for initiating the treatment of an hemodynamically significant PDA? Now we have diagnosed it. So how do we treat it?
So
when do we treat it? Yeah, optimal time.
the optimal time for initiating treatment of hemodynamically significant PDA is an ongoing debate. And then still it is a very controversial, it is a very controversial topics in neonatology, because the most of the PDA spontaneous closures is common in the preterm neonates. And second thing is we don't have a proper randomized control and evidence-based approach for the a long-term association with the early interventions. Okay, and then adverse effects of the drugs are more actually. So the main approaches, like over the trend, there will be different approaches. Is there one is the prophylactic treatment, irrespective of the status of the PDA. We initiate the treatment of ibuprofen to all the preterm neonates in way of preventing the complications like IVH and NEC. So in that benefit, like there will be pulmonary hemorrhage, NEC, all the complications reduced, but they have their own limitations like unnecessary all the babies, even though the babies are expected, closures will be there. Those babies are getting all the major drugs like ibuprofen, and it causes adverse effects. And there is no long-term benefits are benefited with these interventions. And the second approach is the highly targeted approach. In this approach, and based on echo, if it is a large PDA, they'll initiate the treatment of medical treatment on after 24 to 36 hours. If any echo findings is suggested to a large PDA, they will put on medical treatment. In this, advantages like the complications like pulmonary hemorrhage and NEC, IBH, and all will be prevented. The same thing is like the limitation is the most of the babies will get exposed to the unnecessary drugs, and then land up in adverse effects, complications. And recent trending is symptomatic. If a baby is having a hemodynamically significant, like baby having high ventilator settings, white pulse pressures, bounding pulse, and then NEC, and all the complications present, then they will, with the use of echo, they will diagnose the PDA and they'll initiate the treatment. This is the recent trending, and many evidence based also suggestive of the symptomatic treatment, favoring the symptomatic. But they have only thing is, like, we don't know, like, what is the exact dose of the drugs and how many days you should do, which one is the better drug for the PDA, and then whether it is surgical ligations or medical approaches are better. We don't know, like, required standard RCTs are required. And the recent is like conservative management. There will be white and white approach. To favor this, there are the few studies also recently done. One is the uh, uh, PDA tolerance study they done, meta-analysis they done. They all favoring the expected management as compared to the early interventions.
So there are many ways to approach. It has been told. The widely followed one is the one when the baby is having symptoms, and then you do an echo, and if you have symptoms, that what is the time? The early targeted one was in vogue sometime back, when echocardiography people started to do, and they were very enthusiastic about it. They thought that if you target early on, even before the clinical signs appear, then if you treat, the things will be better. But it did not happen. These studies have not shown that it is beneficial. It is beneficial. So people are sticking still to symptomatic one. And now what is happening is that people are seeing a lot of, studies have come that even if you treat, the things are not going to change. There is no change in mortality. There's no change in BPD. So they're saying, wait and watch. Let us do the conservative management. Let us wait and watch, and do non-pharmacological way, like, in trying to decrease the fluid and all. That is called what is called as a conservative management. So people are, while many of us are doing this symptomatic approach, but the conservative approach is the one which is now being thought as the right approach. But we don't know about it still. So, as has been told by Niranjan, we don't have these three kind of papers which have come, the baby Oscar and the PDA tolerate study and the other meta-analysis which has come in 2024. They have not shown that it reduces death or BPD, while in on the other hand, it has shown that there is some kind of harm also. There is a trend towards higher mortality in the treatment group. So that is actually worrying us. That's actually worrying us, that should we be actually be treating or not. So that is the thing which is there. So these studies are still going on. So if we decide to treat, how is PDA medically managed? Doctor
Yes, sir. So
Gafar.
as you suggested, first we'll go for the fluid restriction. We'll assess the fluid. If it is going higher side, then first we have to restrict the fluid because it is a non-pharmacological treatment. And if you want to give pharmacological treatment, we have three options: endomethacin, ibuprofen, and paracetamol, or we can say escitalopram. The mechanism of action is of all the three is same. Like, they decreases the prostaglandin synthesis and they decreases the prostaglandin level in the body by COX-2 and COX-1 inhibitor. Ibuprofen and endomethacin work similarly, but the mechanism of escitalopram is little bit different. It decreases the peroxidase activity and decreases the prostaglandin. But if we go efficacy wise, endomethacin is most efficacious, and it is also used like as a prophylactic drug, because this is the only drug that can be used below before 24 hour of the birth, and the success rate is around 48 to 98%. And if we see the efficacy of ibuprofen, it is almost 70%. Paracetamol or acetaminophen is little bit lesser as compared to these two, but it is most safer uh, drug which is available. If we go, the side effect of endomethacin is more as compared to both drugs like renal toxicity, GI toxicity, and cerebral vasoconstriction. So if we compare these three drugs, so efficacy wise, endomethacin is having better effect, but having more side effect. Similarly, acetaminophen is having good safety profile, but efficacy is lesser as compared to these drugs. The beauty of acetaminophen is that we can right now we can have oral route available for this drug. We can have the IV route available for this drug. Even if the baby is not tolerating, we can use the suppository as well. But for ibuprofen, we have oral only, and for indomethacin, right now we have oral option. Ibuprofen, most some companies came up with IV ibuprofen as well. So we can choose best for the baby. If the baby is having GI or renal side effect, we can go for the acetaminophen.
Yeah.
Yes, sir.
Thanks. Yeah, so these are the things. I think the widely followed one these days is acetaminophen. Everybody tries to use it, IV, but we can also give it oral and rectal, as you have told, because some of them will be having NEC and other things also. And the other most efficacious one is ibuprofen. So these have almost the similar rate, and what we have to remember is that as the postnatal age increases, the efficacy actually comes down. So if it is used early, it will work well. If you use it after 2, 3 weeks or 4 weeks and all, it may not work well, but still we don't know much about it. But the most safest profile is that with the acetaminophen. Then, if those who fail the pharmacological one, what is the role of surgical ligation in PDA? I'll ask Dr. Surinder.
Yeah. Sir, as you were rightly saying previously, once upon a time there was a routine practice of early surgical ligation closure whenever indicated. But now the concept of early surgical ligation is outdated, and even it is only reserved for babies after trying 2 to 3 cycles of medical management if it is failing, or if the size of the duct is large enough and where for anatomical purposes, or where because of the calcifications not able to approach on percutaneous basis. So in those cases only, for a limited number of cases, the surgical ligation is indicated. But uh, there is no role of surgical ligation usually for majority of the babies, because it has been found that there is no change in the outcomes, improvement in the outcomes in the form of reduction in death or BPD. But surgical ligation, we should remember that there are certain side effects like intraoperative risk factors can be there, like pneumothorax, bleeding can be there, or chylothorax. Then there can be accidental injury to the adjacent structures like left main bronchus of the pulmonary artery. And also post ligation, there can be cardiac complications in the form of there can be hypotension or cardiorespiratory instability within next few hours after surgery. There can be left vocal cord paralysis, and that can cause difficulty breathing, and there can be feeding difficulty, so difficulty in ventilation. These are a few risk factors associated with surgical ligation. But
Yeah,
all said and
what
done, we should remember that, sir.
Yeah, but what has happened is that the the studies have shown that actually it increases the mortality, BPD, and all. But that was basically because the babies earlier were ligated very late, when they had a lot of complications and all of them. So that is actually not the right way to look at it. So the surgical ligation done appropriately at a right time
Right
and
time.
right age, it is
Helpful.
okay, it is helpful. It should not be that surgical ligation carries increased risk of BPD and death. It's not like that, because earlier surgical ligation was done after two to three failed courses, very large, the child is on the ventilator for a very long time. You do it very late, and child has hundreds of complications. That child will die of complications, not about this because of this. So
More
that's
because of the underlying illness rather than
underlying.
surgery.
Yes, yes, yes. So I'll ask Dr. Saurabh, what about this transcatheter closure? Nowadays, there is this, non-invasive or less invasive way to, approach. So what about this?
Actually, patent ductus arteriosus was the first congenital heart disease which was treated with the percutaneous closure, and which was started way back in 1966 in a 17-year-old boy. Since then, there have been multiple changes and improvement in this transcatheter closure. And since 2014 to 2021, it has almost replaced now surgical ligations, which represents a paradigm shift towards minimal invasive approaches in PDA. So, what are the indications? Is there are symptoms of congenital heart failure, congestive heart failure, volume overload, high respiratory support needs. There is hypotension, which is requiring inotropes. There is renal function dysfunction, NEC history or endocarditis risk. And those babies who are having more than 2 weeks of hemodynamically significant PDA, which has not been treated despite adequate medical therapy, or in those babies where medical therapy is contraindicated. The echo criteria for this trans catheter closures are when PDA size is more than 1.5 millimeters, when LAO ratio is more than 1.4, the Vmax flow on ventilator less than 2 per second, and abnormal diastolic flow. So, as discussed earlier, the key advantages of transcatheter closure over surgery is that obviously it avoids open heart surgery. It's very safe and less invasive approach. There are less complications. The recovery time is much faster, and latest advances has been, as we can see that devices like Amplezer Piccolo has made it possible that we can do this in very low birth weight, less than 700 grams babies. This procedure can be done. So, what is this procedure? Basically, this is a non-surgical intervention via femoral venous access, which uses a catheter to deliver closure device into the PDA under general anesthesia and imaging. So, there have been multiple devices, device which have been used to close the PDA depending on PDA size and shape. Initially, coils were used, but that led to major complications, especially in the large size ductus, for which Amplezer duct occluder and vascular plugs of various sizes depending upon the PDA size, and Piccolo occluder was used for less than 700 grams infants. So, what are the clinical benefits? Again, faster recovery, only in 1 to 2 days. Hospital stay is required, less invasive. There is no open heart surgery, and there is respiratory improvement and quick activity return. In as compared to the complications in TCC, mortality rate is 2% as compared to 17% in those babies with surgery, and major complications is 2% as compared to 23% in the open heart surgery. There is a 91% reduction in the mortality, and no post-ligation cardiac syndrome has been observed. So that has been basically eliminated, and it's been significantly safer than the surgery. So, what are the still there are some complications with the transcatheter closure. For example, there are femoral vascular thrombosis, especially in the small infants. Device embolization can happen and malposition can happen. Very rarely, tricuspid injury and cardiac perforation can happen. Flow obstruction to aorta and residual shunts can be there. So these are the risk and complications, which are although very less than the surgical ligation, but they are still there.
Yeah, so it is by and large very safe, and people are gaining a lot of confidence and experience in this. And people think that if the patient is really not well, and PDA is causing a lot of problems. There are many centers across the world and in India and in Hyderabad also, where people are going ahead with this trans catheter closure, and the outcomes are really very good. So let's just wind up in last two questions. Dr. Niranjan, now finally, after having gone through the entire gambit of this PDA and all, is there a consensus in the PDA management right now?
Yeah, consensus PDA management still is a controversial and highly debated topic in neonatology because there's a wide clinical practice, everyone having a individual thought process and then treating the PDA. A few points I'll discuss. The one thing is we don't have a universal definition for hemodynamically significant PDA. Like precise definition we don't have. And then in the assessment also, like echocardiography assessment, very complete assessment we are noting there'll be subjective errors will be more. Everyone are not trained in the assessing the echocardiography findings of PDA. And third one is that the clinical science related to hemodynamically significant is a controversial. Like again, it is not reliable. Even though baby having other symptoms related to the pneumonia, any so will be clinical symptoms will be overlapping. So that is a very and then coming to the treatment. So many of the treatment they have consensus like early intervention and late intervention, but the recent evidence based evidence of conservative approach. And if the early intervention is like not helping for the preventing the PDA related complications like BPD or NEC, and a few medical treatment like paracetamol is lesser toxic, but still the dose and duration is still we are not defined properly. And few of the RCTs are required to know the long-term benefits of neurodevelopmental benefits associated with the relation between the neurodevelopment outcome and surgical closures. And timing and initiation of the treatment should be well defined. Still, it is like is under research process only. So these are the things that are very controversial and need a further studies.
So although we know a lot about PDA, but still there is no consensus about the PDA management. So because there's so many issues about it, we have just gone through it, and you have nicely told about all these things. And nowadays, more and more people are going for the conservative management. And when it comes to intervention, it is the trans catheter one. And if you see the consensus level, there are a lot of people have a conflicting views. There is, consensus is far away. It still takes time. So finally, we'll ask the last question to Dr. Jafar. What are the future directions of PDA management? Dr. Jafar, are you there?
Yes, sir. Can you hear me?
Yes, yes.
Yeah. As Dr. Niranjan rightly said, there is a lot of controversy in the PDA management and diagnosis. So we have to standardize the HSPDA definition, whether baby is having high hemodynamic segment PDA. So we have to validate consistent consensus based scoring system needed to define the grading of the HSPDA severity and enabling the consistent clinical language and improved trial design. So there will be a unified diagnostic criteria across the institution so that we can say this PDA required treatment, this PDA not requiring treatment. The next thing, we need improved clinical trials, like we need randomized control trial that will tell that will enroll only high risk infant with clearly defined HSPDA with minimum treatment crossover and focus on the long term patient centered outcome. The target high risk population with clear inclusion criteria should be there, and we have to focus on the individualized management, whether the personal strategy for the individual patient based on the clinical echocardiographic and biomarker based tools to identify the infants most likely to benefit from the treatment, and which baby will not require treatment, that we have to identify. And we have to uh, that research on innovative therapies like novel drugs with higher efficacy and with less significant side effects. And we have to redefine the transcatheter closure technique for very small newborn infant. And we have to focus on the advanced monitoring imaging like real-time physiologic monitoring and emerging technology that can better assess the hemodynamic, predict instability, and guide timely and precise PDA manages. We implement continuous NIRS monitoring for tissue oxygenation and advanced 3D cardiography for detailed assessment. We need the training of all the neurologists for the diagnosis of PDA. Yes, sir.
Yeah. So, thank you very much. So what it means is that to bring about an consensus, we need to have proper trials. We need to have people. The inclusion has to be in a proper way. We need to the inclusion should be based on some scores. Not because if you see all the studies, they will only say only one of the parameter, LAAO ratio or some other thing. So it's not the inclusion of the patients in the trials is not proper. So how can we tell about the this outcomes? So everything has to be, so they have to be a proper inclusion. They have to be proper. This in our cities have to be there. So only then we can say that whether the treatment is beneficial or not. Right now, we still don't know whether the treatment is beneficial or not. Please don't go with the earlier reports. There are pharmacological methods, there are interventions available. So, for all the fellows, I want to say one thing is that you should be doing an echo only if the clinical signs are there. Unless it is an extremely low birth weight, below 28 weeks, you may do an echocardiography to see whether the child has PD or not, but not to treat it. Treatment should be based on basically on whether the child has symptoms or not. If the child is asymptomatic, wait. If the child has symptoms which can be because of PDA, then, and if the child has an hemodynamically significant PDA on echocardiography, only then we should treat it. So I'd like to see if there's some kind of questions or I'm not able to see the chat. So there are no questions. There are only somebody wrote excellent. Is there any question answer thing? Doctor,
No, I don't think there are any questions are there. People could have
yeah, there
given in the
is
chat first.
somebody has raised a hand. Can unmute and you can speak if you want to. One of the this audience
If anybody wants to ask, they can unmute and ask actually.
So I think one of them have.
Can I say something?
Yes. Who is it?
Dr. Lakshmi from Chennai.
Yes. Dr. Lakshmi.
Excellent presentation. I don't know about the postgraduates, but we thoroughly enjoyed your presentation. Very crystal clear slides. And you had went through all the nuances of PDA, the controversies and everything. So I just want to thank you for an excellent session. Way back 15 years ago, we have used a lot of IV indomethacin as a prophylactic measure or for HSPDA in less than 27 weeks. And I'm seeing that group of children now, they have an excellent outcome. So I really used to miss indomethacin. Why this drug went out of market.
Yes.
I have a group of, I can even publish it, 18 to 20 children who are below 27 weeks, where I've used IV indomethacin and given a real good long-term outcome. I just wanted to share this. Thank you so much.
Yeah, thank you very much. So I think, are we done?
Yeah, we are done, sir. Thank you, Dr. Ravisankar, sir, and all the panelists for a very insightful, informative, and exciting discussion. And it was really a pleasure to hear the panel headed by Dr. Ravisankar, sir, and ably supported by all the young panelists from various parts of India. And I would like to extend my heartful thanks to Dr. Ravi Shankar and all other panelists from the NOEL team. Thank you, sir.
Thank you very much. Thank you.
Until meet next Thursday, this same time. Thank you. Thank you, sir. Good night.